Can y'all hear me okay? Awesome. Well, Jamie and I are here to talk to you guys about patient experience and how more than images, how patient experience actually shapes radiology. So I first want to tell you a little bit about myself and how this nurse practitioner got into the radiology space. So I started my career, my organization as an ICU nurse. Was there for, ICU for about 9 years, went back for my nurse practitioner degree at my institution, had to leave for 10 years and did primary care, came back to this organization because really of the culture, and I love academic medicine. So did urology for a few years, had enough of that, and met an old colleague. It's like, have you ever thought of coming to radiology? I'm like, no, not at all. What can a nurse practitioner do in radiology? And so they needed a nurse practitioner in the MRI space to basically assess all of the MRI sedation, all the claustrophobia patients. And so this was a totally new role. I stayed in that position for about 3 years and then became chief over our NPs and PAs. So that's where I got into leadership. Did that for a few years, and now for the past 3 years, I've been the director of patient care services and in the outpatient ambulatory clinic space. So long career. I plan to retire from this academic institution. So it's been a great career and happy to be here with y'all today.
Yeah, and I'm Jamie Dennis. So trying to show you that nurses can be friends with technologists, right? So I'm a technologist by trade. My specialty was in CT. I was there for 5-6 years, started getting into leadership, supervisor, manager, continued moving on, and then I was our site director, and now my role is actually program director for patient experience only in radiology, right? And I work closely with our hospital patient experience team, along with all of our OUs, and we'll kind of talk about our structure here in a minute, but I've been in the field for 25 years. We always say it's the radiation treatments that keep us looking young. But kind of just talking to you really today about how we can change that shape and that focus of patient experience within our own radiology area.
Awesome. And we have no financial disclosures. Our objectives today is to provide you with a historical overview of the patient experience in healthcare and what we did to actually improve our patient experience in radiology. We're going to examine how radiology influences patient experience across health systems, identify imaging modalities with the greatest potential for patient experience improvement, and sort of focus on some of our pre-committee work. What we really want to do is give you some strategies that you can take home and implement. You may not be able to do everything we did, but there are some things that you will be able to take home and implement very simply. Analyze post-implementation data. So we want to show you how we implemented these strategies and what our actual metrics showed afterwards. We want to talk a little bit about leader standard work and the importance of staff recognition, because none of this works if your staff is not engaged. And then discuss where we are at this point and how we're going to move forward.
So really how we got into this was Emory, our healthcare, changed the entire structure of our OUs, right? So started off that we had 5, 6, 7 different OUs, and we had a traditional model where we had site managers and site directors at each OU, right? So when I was there, I was manager at one point over CT, MR, IR, nuclear medicine, and the breast center, right? Again, I'm a CT technologist by trade, so it was learning everything about those other modalities, and that's like sometimes a typical model. With the organization continuing to grow larger, they changed it from being siloed into the different OUs, but more into a overall system approach. So we have one senior VP over all of imaging, and then we now have directors over each modality, and then they cover across all of our campuses. Initially, we had a site director at each location still as that point person, and that's what I transitioned into. But when we took this approach, we realized that there was a greater need for also looking at patient experience across every single campus, right? So if you go to hospital A and then you end up going to hospital B the next time, you want to make sure that that experience is the exact same. So we took that approach of starting this committee and really forming it that way. So with that, we took this approach that currently we have over 1,700 people just in radiology, from our technologists, staff, physicians, over 10 hospitals, outpatient clinics, various imaging centers. We do a ton of studies, obviously in interventional and then also just naturally. And then the biggest thing that we always say is 93% of all of our patients that come into our organization come through radiology at some point, right? And I'm sure it's the same where you guys are working. So that's where we play such a huge part in every single patient that enters the door, right? So you guys know what we do, but kind of just wanting to take a little poll. Who in here are frontline technologists? I know you mentioned that earlier. Who are our supervisors, managers, directors? Majority, great. Who else do we have? Okay, perfect. Just so we have an idea who we're talking with, right? So really, why is the experience important?
So when we were Jamie and I were kind of volunteered to take on this committee. I think they knew that we could get it done. And so we had to examine, why was this important and why were we being asked to form a committee that focuses strictly on the patient experience? Well, there are several reasons. When you have a poor or great patient experience, it impacts your patient safety. And we know when it's great that it actually reduces errors. And of course, we have to, our hospitals are measured with HCAHPS. It's a quality measure that tells you how well you're taking care of your patients. Also, Centers for Medicaid and Medicare requires 300 inpatient surveys per year for a hospital. And then there's value-based care, right? So a lot of hospitals have contracts with certain insurance companies, and you have to meet certain metrics, and that determines your reimbursement. So if you don't meet certain metrics around quality and safety, you don't get the full reimbursement. So that's also, and a part of that is how patients are likely to recommend your particular facility. In Atlanta, we're in a very competitive market. We kind of used to kind of sit along with some of the procedures that we perform and do, but now, our competitors are doing some of the same things. So how do we set ourselves apart? And it's going to be around patient experience. So our reputation has always been good, but we realized that we still had some work to do. And again, patient expectations, man, patients, it used to be, I used to say, well, you don't have to do all these special things. They're coming to the hospital to receive care. They are, and they expect very great care and quality care, but they also want like this 5-star experience. Like when you go to a 5-star hotel, they do want the warm robes. They want you to greet them. They want to be communicated with, just like going to, a nice restaurant. And then they want us to show empathy and be compassionate about what they're going through. And in radiology, what our patients are either coming for initial imaging because they saw something, or they may be diagnosed with some type of condition, or they may be an oncology patient. And this particular MRI is going to determine, was my treatment successful or was it not? And do I have to undergo more? So our environment in itself, our patients are usually pretty stressed, and just recognizing that. So I want to talk to you about Janet. This is a patient example of when things don't go well. And this is not a very uncommon scenario, but she's a 63-year-old patient. She arrived 15 minutes early for a scheduled outpatient CT scan, waited in the lobby for over an hour, for over 90 minutes with no communication. And when she went up to inquire about, she was basically told, we're running a little bit behind. She was given no other information. So when the technologist came to get her, he or she appeared unprepared, asking questions. Janet basically was frustrated, felt unheard and anxious, and the procedure finally was completed 2 hours late, nearly 2 hours later. So Janet's going to receive a survey from our survey company, and on that survey she put, I felt invisible. No one told me what was happening. No one checked in, and I left with more questions than answers. So we don't want the Janets of the world, that we need to turn this around. And it's like Jamie was saying, radiology, most patients in the healthcare system are going to come through radiology, 93%. And so what we were being tasked with, our system leaders recognized this year, like, oh, for instance, breast imaging, because of the volume of breast imaging, you are affecting our system scores. So basically, y'all need to get it together and improve your scores. So I'm going to turn it, no, not yet, but how do we measure that? So for us, we use one of the major survey companies, right, that send out surveys on all of our patients. And so they provide the data analytics and performance improvement strategies, because this is the way you collect the voice of the customer. Like, how do you know if you don't ask how you're doing as a hospital system or a clinic? And so they actually provide us with strategies to improve in those areas that we are sort of failing in. So radiology's approach to improving the patient experience metrics. I'm going to turn it back to Jamie.
And I think that's the biggest thing, right? Is you guys, if you're using a different survey company like we are, we're paying for it, right? We're getting the voice of the patient. Then what are we doing with it? Right? Because if the patients are literally telling you this is what the problem is, and you're like, all right, cool, and you keep going, you're not listening to what they're saying. So that's really why we were taking that approach, to see what we can do and really formulate it. So when we formed our committee, again, being volunteered, voluntold, whatever you want to look at it, it was me, myself, Tracy, and then one other person at the time. And we really kind of had to get together to be like, okay, what are we going to do, right? Who are we going to involve? Because obviously it can't just be the two of us for this entire organization and the entire radiology area. So we kind of sent out like a call to action. We asked multiple people. We ended up the first time with about 86 volunteers, truly volunteers, and we had everybody from our frontline staff to our managers and directors, right? We also had everybody from every single modality, and then every single OU or campus that we represented. So when we first got all together, we had a kickoff meeting in September, and I think that was the first time that as an organization, we had every single different level of staff, every OU represented, and every modality represented. And I know we were all extremely proud of just bringing everybody together, including our nursing team, right? Because we had some of our nurses on there as well. Again, that's the way you're going to hear what happens and really get the voice of that frontline team member, because they're the ones that are seeing it every single day. So then we formulated our CARES committee. Everything is in green. I don't know why that's kind of messed up, but so that's why Tracy and I are in green. So at the time we went through and we were like, okay, we want to have that like Pavlov's effect. Whenever somebody sees us, they're like, oh, you're in green, you must be for patient experience or CARES, right? So every time we talk, every time we do anything, we are intentionally in green. Some people asked us why green, you know, well, red, you always think of like cardiac or heart. Pink is breast center, so we didn't want to steal that breast center thunder. At the time, our organization was blue, so green was the next one to look at. It also has a calming effect. It's like environmentally friendly, you know. Since then, our organization has now recently added green. We keep saying they're stealing our thunder.
Right.
As you see here, they're going to steal a lot more of it, but we like to say we're just paving the way for them, right? But really taking that CARES approach. So collaboration, advocacy, respect, empathy, and service. So this is, again, how it spells out those core models. So it's very easy to say, you know, we're part of radiology, we're part of CARES, and then what this means. And this is just another way that we kind of highlight it and focus it. And again, we're not going to read everything in here. The biggest thing is that collaboration, right? Encouraging open communication, shared decision making. Collaboration against our coworkers, right? Collaboration with our nursing teams on the floors. We know sometimes we're in that ER and it is crazy and we go to get that CT patient and there is that butting of heads, right? So really trying to collaborate with those colleagues as well. Advocacy. How many times do we have to be the advocate for the patient because they can't speak for themselves, right? We're the ones that know, okay, this order is not correct. We know that, but how can we try to get it to where we're being that voice for the patient? Treating everybody with respect and dignity. We all know we're supposed to do that, but sometimes we forget about that. And not just patients, but it's those patients and their families and caregivers. Empathy, like Tracy mentioned, always showing that empathy, that compassionate care. Sometimes people forget that along the way too. And then service, right? We want to make sure that we're providing that excellent service in everything that we do going forward. So Tracy, myself, and Lucienne, we had multiple brainstorming sessions, multiple meetings, like, okay, we've formed this committee. How are we going to break it up? What are we going to do? So that's really where we decided to kind of focus on three main areas. One of them was on those Press Ganey, or those surveys, we use Press Ganey, that Tracy talked about. Looking at our service enrichment training, and we'll talk about all these a little bit more, and then our external access and information. And then Tracy was our queen of our survey, so she's going to give you a lot more detail about that.
So first, before I start on this, I want to tell you that this is a symbol of empathy, this chair. And I will tell you why, because if we are assuming that every patient can walk into the MRI scanner, and that's not right. So we have to, if you don't have an MRI compatible, wheelchair, I guess you have to maybe bring him in on a stretcher, right? But this is an example to me because we're basically anticipating the needs of a patient because everybody can't walk. So I think this is thank you all for developing this, but it's a great example. So what we did with our patient survey class, I actually created a whole curriculum. It was 3 classes. Back to the basics was the first one. And what we realized was that a lot of our leaders did not know how to interpret the patient experience metrics. Not only did they not know how to interpret it, they didn't even know how to generate a report. And everybody was getting something different. And so we wanted to standardize to make sure every leader was looking at the same thing. We're looking at those same comments every 2 weeks, and then our LTRs, likelihood to recommend scores, every top box scores every month. So we developed this curriculum. All of our directors and managers were mandated to come to the class. We did have a survey expert that was a system level person who helped everybody actually show them how to generate their reports. And so it was a learning experience for me as well. So in order for the committee, we had several committee members, maybe about 10. We had to kind of learn too, because we didn't know either. So she taught us so that we can teach others. But it was a hands-on training. So far, we've trained 70 plus leaders. We've got it pre-test, post-test, and the class has been very successful. And
And I was going to say, before Tracy goes on, because she's not going to toot her own horn, I'll toot it for her. So the system actually recognized that this was an issue, not just like with us, but across the enterprise. So they've actually developed a similar class that all leaders have to go through for the entire organization.
Yeah, very successful. Thanks, Jamie. And then the second class focused around leader standard work. So, okay, we taught you about how to retrieve your reports, what are you supposed to do next? So we developed, our second curriculum was focused on the customer service experience. And we compared, companies that do customer service very well. Who can name a couple of companies that always provide consistent service? Chick-fil-A. Any others? Yep.
Ooh, that's good.
Any others? Those that are popular. I'm from Georgia, Florida, so Publix is one. Four Seasons is
Delta.
Delta. Buc-ee's. Who's Buc-ee's fan? I think they are awesome. But it's consistent no matter where you go, what state you go in, it's consistent. And so with an organization as big as ours, how do you make sure, because our patients go to different facilities. So if I've gone to 3 different places for my mammogram, and I will tell you, before now I had a preference because they did a little bit better over here. They were more on time over here. The technologist didn't hurt me as much over here. So we've got to make sure we're consistent. So we established a platform for our leaders to follow around expectations for the patient experience. But this class also focused on employee recognition. We mandated that every department had to have some type of employee recognition platform. Doesn't have to be anything great. It doesn't have to be anything expensive. It could be just looking at your comments and calling out, John, hey, a customer mentioned you, a patient mentioned you in the comments, and giving him, we have points and cards and stuff that we can give out. But we also focus on what our top 5 problems were around radiology. Registration. Our radiology front desk staff, they don't report to us. So we had to collaborate with those leaders so that they can become a little bit more friendly. Waits and delays. Wayfinding is huge at Emory. The system has been working, have done a lot of great things around that. Parking is often a mess depending on where you go. Some places it's great, other places it's not. It's expensive if you valet, but we don't have control over that piece. And then the empathy piece, just kind of, COVID changed a lot for, I think, the way we interacted with patients because we were trying to stay alive. We were trying to keep patients alive. We had on these masks. We didn't want to talk. We didn't want to interact. It was really quick getting patients in and out. And so now it's time to kind of come back to some of those basic things that we used to do from the customer service. The last thing, when we basically tiered, which you'll see later, all of our facilities. And we basically took the 3 low performing areas, and this became our 3rd sort of class or initiative. So our 3 low performing areas were consistently across the organization was MRI, breast imaging, and interventional radiology. Where I live in IR, wasn't surprised at that. So we partner with those leaders to specifically look at their scores and comments, and we developed a strategy. And I will say I'm going to toot Jamie's horn because she's the one that's been doing most of that work. But that was focused on our likelihood to recommend scores. But even those departments that were doing it right, we're partnering with them too because we know that they can slip. And so we recognize them from doing a great job. And like I said, we've had great system leadership and resource support for our committee. But to briefly go over what was that leader standard work, we know the importance of leader standard work because it gives everyone a structured approach to leadership and it lays out those expectations. And so everybody is doing the right thing. So some of the things that we did were recommended were Gemba walks. And I challenge you all to do this. Just go sit in your waiting room for 30 minutes and observe. And you'll get a great, you'll get great insight on what your patients are experiencing. Look up at the ceiling and see if there are things maybe about to fall or the ceiling tiles are dirty. Go in the bathrooms. Listen to the noise. Observe your front desk person to see how he or she is interacting. We do safety huddles. We do frequent check-ins with staff. We do leader round, and we're mandated to round. How often do we have to round per month?
Yeah, 5 times now. So yeah, we started our outpatient. So, as Tracy mentioned, inpatient eye rounding is like mandated by CMS and that type of thing. So we started our outpatient eye rounding, right? Trying to catch those patients as they're leaving. And I was talking to a patient and we were walking down this hallway and she's like, I feel like a basketball star where I'm being interviewed post basketball game because I was talking to her as we were walking out, I was like, it's a quick 3 minutes or 3 questions. Just how was your experience today? Trying to get that real-time feedback.
Yeah.
And as Tracy was talking about with the Gemba walks and sitting in your areas, right? We all do EOC rounds, right? All the time, you have to. How many of you do waiting room rounds, right? I love that. So that's one of the things that I do, and I have a form and I fill it out, like Tracy said, what are they seeing? What are they hearing? I hate going into a bathroom and there's no place for my purse, right? There's no hook, or there's like the teeny tiny hook. I have a big bag. Okay, is my bag gonna break it? Especially in the winter, is there a place for my bag and my jacket, right? So like all of those things from that patient's perspective, as Tracy mentioned.
And those are relatively simple, inexpensive things that we can tackle. But we also wanted to make sure that leaders were displaying this visually on either huddle boards, or whether it was a virtual huddle board or actual huddle board within the department, to say, okay, this is where we are on our patient experience metrics, and also like doing kudos and things like that. But what's been really great is that this has been incorporated into our culture. So we, on daily huddles, we have a lot of huddles. We talk about patient experience. We recognize, areas that are doing well. Um, they're in our weekly meetings, and basically we use an A3 approach to kind of problem solve. And but the big thing I really want to emphasize is this: is the employee recognition, because we know when employees are recognized and feel appreciated, basically the overall success of the company is better. And also your safety, when you have employees that are recognized and happy and not burned out, we know that patient safety is also improved. So it boosts morale and motivation, it enhances job satisfaction, improves employee retention. Of course, in healthcare, our techs and nurses have so many choices, and we're already short-staffed, so how are we going to retain those? Encourages healthy competition for some. Productivity is usually increased. They're more loyal and committed to stay. Encourages personal and professional growth, and promotes teamwork. So that's really, really important. So Jamie's going to talk about our second committee.
And I think, and aligned with what Tracy was saying too, is about recognizing our staff. We're not just walking the walk and talking the talk, but we're walking the walk, right? And we've had some newer team members that have come over from other organizations. And within less than a month, she said, I can already see that you guys are doing what you're saying you're going to do, right? Which I think was a huge thing for us. So the next big thing we were looking at was our cultivating excellence. So pre-COVID, again, we know everything changed. We used to have a Service Excellence Institute where we did a lot of training just for radiology staff itself. It was staff, frontline staff, managers, directors, also our physicians, APPs. They go to med school, they do a great job. They know how to do that IR procedure. Do they have the best bedside manner? No, we all know that. It's like you have to come out of that dark space and actually talk to a patient, right? So we did an 8-hour class where we actually did a lot of that hands-on frontline training, customer service stuff. Obviously with COVID, it went away. So we were like, how can we bring it back? So we changed it from the Service Excellence Institute to our Cultivating Excellence and Enrichment Training. Again, and these were some of the main things that we were talking about, right? We wanted to have that unified approach, right? You go to Chick-fil-A, they're always going to say my pleasure. We joke around that, okay, if they can teach teenagers how to say my pleasure after every single experience, how can we not teach adults to say thank you, right? Chick-fil-A and some other organizations, they have 200 plus hours of customer service training. We're at State, we had like 0, right? Because a lot of the training had gone away since COVID and we hadn't brought a lot of that back. So it was really trying to get back to basics. Don't make it this big, huge, elaborate thing. You can make it small and basic. Say hello. We use ADIS, acknowledging the patient, identifying who you are, right? They talked yesterday a lot about managing up your coworkers, managing up yourself. I'm your technologist. I have been doing this for 20 years. I know what I'm doing, right? I'm registered. Give them that duration. It's not, oh, this will be a few minutes. Well, your few minutes and my few minutes might be vastly different, right? This is going to be 5 minutes or less. Explain what's going to happen, right? You get that better buy-in with your patient when you actually explain what's going to happen. Thank them. As Tracy mentioned, we have tons of competitors. Thank you for choosing our organization. Thank you for letting me take care of you today, right? They didn't have to choose this place. Nobody wants to be here, but they still opted to come to your area. And we added on the H for hand hygiene, right? We know that's a big thing too, so that's where we get the H from. But having those different pieces, working with empathy, again, emotional social awareness. Again, we cover a huge area in the Atlanta area. Every single location has a slightly different demographic. We also have a different generation of patients coming in. We have different ethnicities of patients coming in. So also trying to manage all of those different pieces of it. It's not one size fits all. right? Looking at spiritual health, again, providing or prioritizing empathy, and then also wellness resources for our staff, right? We hear so often about that work-life balance and burnout. So what else can we do to help our staff so they're not feeling the weight of it as well? So one of our classes that we've done and we've started is the heart of service recovery, right? With all of our structure changes, we also had to look at how are we helping manage those patients that might need a little bit more attention. I always call them the Karen or the Ken type of thing, and they get a little bit rowdy. And we're not always going to have that same supervisor, director, manager on site, right? Because we've also extended a lot of our hours at our locations. So we're doing exams sometimes at 7, 8 o'clock at night for outpatients. We're doing exams Saturday and Sunday. We have our breast centers open 12 hours Saturday and Sunday, right? So if Karen starts acting a little unruly, that manager is not coming out of the back to help talk to that patient. So trying to give the tools back to our frontline staff. So we worked with our system patient experience team to make sure that we were using the heart method, they're using it too, right? Because we don't want to teach something different that the hospital is doing. It's a 2.5-hour class. I teach it. There was 2 of us, but again, she has went to a different section of the hospital. And we've had over 90 people that have attended the class. Everybody has said it's fantastic. We're opening it up to our frontline team members, and some of it's basic. We're going to hear you, we are going to thank you again for talking with us. Let's see how we can work together to fix this problem versus, oh, this is a you issue versus now this is a we issue, right? It's basic information. We're doing it already. It's just providing the staff with those tools to help them get there. The next big area that we looked at was, again, all of that external information and that piece of it. So this was a huge committee. I worked on this one. Again, communication is key for everything, but again, formatting the way that we're looking at it. Again, as Tracy talked about, we have a lot of the information out there, but how are we actually showcasing it for everybody, right? Really looking at that report out for our different huddles and that structure for it. We report out on Thursday at our operations meeting, right? So we go to those meetings and we tell them, like, this is what we're doing, this is what we're seeing. Having that partnership again with our frontline staff members. All of our OUs, we have various meetings at the OUs where we tell them what radiology is doing, where our scores are, and what our big focus is, and also what barriers we're having. I was working with one of our team members at our large location downtown, and again, we know parking, traffic, all of that is a huge issue. So the organization launched this very large wayfinding app, which is great. Nobody knows about it, right? Even people that were working in there, they were like, oh, I didn't know we had that. And I'm like, if you guys don't know, how do our patients not know, right? So I talk about it at every single meeting we go to. It's like, we have to get this information out there. Working on an intranet page or a SharePoint page for our frontline staff to be able to go and resource and to be able to use. Because we've done so much work. Tracy and I are not at the front line working on it. So how can we get that information back to those team members, right? So having it very easily for them to access and get to it. And then we wanted to look at everything that our front line and our patients are seeing, right? So this very large section here, website, we completely overhauled the website. So taking a look at it from that very fresh set of eyes, and what does this look like? When the website was initially created, it was created by some of our fantastic physicians. Patients don't understand things from that physician level, so we had to change the way that it was being viewed, right? We do passport cards, and I'll show you that here in a minute. What that looks like, looking at videos that we have for our patients, looking at that discharge information. You go to IR, you get your discharge paperwork, it's 7 pages. Why do I need 7 pages for a port placement, right? When really 30 seconds of that 1 page is really all you need. So let's revamp how they're getting that and they're receiving that information. Because if you give me 7 pages, I'm throwing it away. If you give me 1 page with really valuable information, now I'm going to keep it and I'm going to take a look at it. Looking at water and coffee and having that standardized. Again, some places have it, some places don't. But what does that look like, right? Is the coffee readily available? Is it prepackaged? Do you have the sugar thing that you pour in there that now has got everybody else's germs on it? Is it making more of a mess? Some areas had coffee and sugar, and then they found out they had lots of bugs. So it's like keeping track of all of that. And then again, if you offered at one location, you would offer it at the next. Well, I was over at that hospital and they had coffee. I don't have anything here. So trying to standardize all of that as well. So this is what our passport cards look like. So some of our locations had this prior to us going centralized, but each one was different. So we took all of the passport cards that we had. We had, I think, 6 or 7 different versions of it. We had a committee of about 7 or 8 people that really worked on this together, trying to decide what's going to be the biggest, impact for our patients. So we really wanted to make sure that we were highlighting not just the technologists, but our frontline staff who are also registering the patient because they do a great job, right? We want to make sure the staff are being recognized. And then on the other side, I hate saying front or back because depending upon how you look at it, what's going to happen next, right? We know that's always the question. When am I going to get my results? How do I get my results? Oh, and now I need a copy of my images, so who do I go to, right? All of this information is right there at their fingertips. And then, of course, we want to hear from you, the patient. You're going to get a survey. Please fill it out. Tell us how we're doing, right? Super simple. It was also a very intentional thing to hand somebody. They talked about it yesterday in one of the classes. I'm trying to think who mentioned it about like having that tangible thing that you leave with, right? But it's also that very intentional thank you for choosing our location and coming in again because you're letting us take care of you. So we launched this in June, July. At some areas, we were doing like a soft launch in our rollout. June, July, August is really, we did like the full thing. And this right here is just our survey responses across all of our campuses. So you can see, mid to low 6,000s type of thing. When we launched it in July, we went up to 7,000. August, we had almost 8,000, right? So from when we initially started at 5,400 to our peak there in August at 7,800, right? Hopefully what we're also capturing is we're capturing those patients who are on the fence of like, they did a fine job. Because usually whenever you get that response back, it's because you guys did excellent or not so great, right? We always hear the negative stuff. But you did a really good job. We really do want to hear from you, The other thing that we noticed, because we're giving this patients the names, we're not seeing a lot of, well, I don't know, remember who took care of me, but it was the nice person in the green suit. It was the person in the gray scrubs. Everybody wears gray scrubs. Who that is, But really trying to help identify, again, the staff that are taking care of the patients, because they're the ones that are doing the great work. We want to recognize them for doing the great work. And so we've seen that tremendously as well.
And I will also say the reason we do this is to drive our responses up. So our N number, we want it to drive up because the more responses you get, the chances are, if you're doing a good job, it's going to drive your metric positively. So the more patients can fill out surveys, because like in interventional radiology, we would get like, maybe 9 or 10, surveys. And if one person said something negative, that drove our score down. So if we push this to have more people do the survey, and the organization does a great job of pushing the surveys too, then that's going to increase your chances of getting higher likelihood to recommend scores.
And we know it's also like survey overload, right? You go everywhere. Mm-hmm. You go to Chick-fil-A, fill out our survey. You go to McDonald's, fill out our survey. I'm going to go to Delta, fill out our survey. So it's like, I'm not filling out the survey every single place I go. I try to be more intentional about it now because I want patients to fill them out for us. But I think when you ask them also, you do sometimes get a little bit more of that buy-in. Like they really do want to hear from us, mm-hmm. So then, like Tracy mentioned, we were really trying to take that top 3 areas of what we wanted to focus on and tiering those different areas. And so this right here is just, green was anything above that 88 point or 90 percentile there for those top areas That middle blue area were things they were kind of on the fence. They can go higher or lower. But then obviously that very long list of reddish color there, those were areas that were those lowest performing. And that's where we really identified, again, interventional, breast, and then MRI. So, and then Tracy's going to talk about how we worked with each of them individually.
So, so basically, we took a deep dive into basically the comments for those three modalities and looked at, first breast imaging. And I guess it was September 2024, you can see where their likelihood to recommend score was 80.24. So their issues were waits and delays consistently across all of their sites, lack of patient communication, and the patient just didn't understand what was going to happen to them. And so breaking all of that down, we sat with the leadership team and we let them come up with the solution. They work there, we don't. So what can you do to improve your scores? And they came up with, performing. So they began to perform pre-calls for their diagnostic and biopsy patients, just to explain, this is going to happen to you. And one of the things I will tell you, working in the ambulatory space, in the diagnostic areas, we do a good job in IR of preparing patients for procedures pre and post. There are a lot of diagnostic areas that do procedures, but they don't have the same clinical model to prepare those patients pre and post. So patients show up, for a breast biopsy. It's pretty darn scary, I would think, and they have no idea what's going to happen to them. So they really begin to focus on that. They had TAs or tech assistants to start rounding on patients in the waiting room to explain waits and delays. It's like I was explaining in one of the classes yesterday, give me the option of staying or leaving, because we're all busy, patients are busy. So if it's going to be an hour wait, I expect it to be in and out in 15, 20 minutes. So I'm going to, to leave and reschedule. So, and opportunities for just retraining the employees in those areas. IR, IR, my home. I knew all of this because I lived it and hear it from our patients. It's a very challenging area for a lot of reasons. And our physicians sometimes just focus on the procedure. That's all they want to do. They don't want to talk to the patient beforehand. Patients don't know what's going on. But anyway, lack of empathy, lack of communication. They, a lot of comments. We want to see the doctor that's going to be doing this, but they bring them in the room, sedate them, and they don't know who's doing their procedure. A lot of lack of patient education, pre and post, especially a lot of our patients don't come through our clinics. And so they don't get all of that pre-care that they should. Inadequate pain medication during the procedure. That to me was painful to hear that patients weren't being medicated properly. And like I said, lack of MD interaction. So we had to get with this team because as you can see in September, their scores were 75.34. And I didn't say that on breast, but the implementation, you can see as of July how much that improved. 15 points just by implementing these strategies of just slowing down the patient here. They're scared, and making sure that you give that patient undivided attention, not just the physician, but the nurse and the tech. Like, tell them what's about to happen. Introduce yourselves. That's a pet peeve of mine. A lot of different things are different for people, but I want to know who you are, because it's hard to see sometimes behind the mask. But improved communication, again, around waits and delays, that was huge. And then the last one was MRI. MRI, I found out, was a very specialized area. I had so much respect, had no idea until I started working at MRI how technical it was. But as you know, in one particular, in our main, what I call our main campus, we do in MRI, we do outpatient imaging. We have patients coming outpatient. We do the inpatients. We have procedures, neurointerventional procedures, other procedures in that area. So it's a very high-paced, stress area. And so a lot of waits and delays, lack of communication, One thing, patients, like they put them in the scanner and no one talks to them. Just something really simple. They don't do mic checks. That's something we implemented. So strategy, do mic checks. And what the team said, well, everyone doesn't want to hear you coming in every 5 minutes asking them. So they begin to ask the patient, would you like us to do a mic check every 10 or 15 minutes? Patient said yes, and then they would check on them. But we had just lost those basic things. We did ADIF training with their staff, communicated with patients around waits and delays, reviewed scores and comments with staff so that the staff was able to see these are, because y'all, the staff just didn't know. I mean, if we aren't telling them what the problems are, they didn't know. So giving them that information, I mean, they were happy to begin to do these things. So as you can see, 84.8 with implementation, they improved tremendously around those implementation strategies.
And with that too, like even for breast, for IR, for MRI, we kind of joked around, like talk about the elephant in the room, like we were talking with the MRI leadership team and we were talking, like, talk about the elephant in the room. And he was like, you mean the big magnet? Yes, talk about the big magnet, Don't be like, oh, it's really not bad,
Yes, it is.
No, it's big, it's loud, tell them that up front. You're going to have your mammogram. It's pretty uncomfortable, or it can be uncomfortable. We're going to make it as comfortable as possible for you, right? Don't sugarcoat it. Tell them, because then the patients also realize you have that trust with them and everything else, and they know what to expect. So this is just kind of a quick glance as to where we are. So just for kind of awareness, so for our FY25 year to date for MRI, they were at 85.4, and you can see now they're at 86.26, right? Again, not any increase is better than anything, right? IRs dropped down a teeny tiny bit. They were at 83.1. Now they're at 82.69. Again, the biggest challenge we have with IR is getting those responses back, right? It's hard when you only see 10 patients. You're not going to get 10 responses back. So really making sure that every patient has that great experience. Breast, they were at 81.89. They've gone up to 84. Huge jump in that breast area. And then this is our overall radiology score across all of our areas. And you can see again that huge change in that July, August timeframe when we were doing that big push for those passport cards, giving that information back and doing a lot of the various strategies of getting that information out there. And currently for February, so far we're at 87.25. We hit that 87 mark. That's really what our goal is. And then so wins and opportunities, and I know we only have a few minutes left, so we'll kind of go through this quickly, or we can always stop and ask for questions. Talk about Marcus, again, changing that experience for him overall. He has that good experience, our success, giving it back to basics, right? That was the biggest thing. We do weekly themes. So every week we talk about something. They put it on their huddle board. They talk about it in their modality leadership. First one we did, super simple. Stop and smile at 5 people when you're walking in the hallway, right? The next week we did swap that scroll while you stroll. How many of us are guilty of walking in the hallways looking at our phone? I know I was, sometimes I still am. So it's like challenge yourself for 24 hours to not look at your phone when you're walking the hallways. Make that eye connection with somebody else and say hello to them. It's a completely different atmosphere environment when you start saying hello to people in the hallways. Patients feel it also. Again, employee recognition, looking at that, making sure it's standardized across the entire system. Introducing not just our staff to the culture, but our patients to that culture. That's the big shift as well. And then looking at those, again, various opportunities, again, trying to make sure our physicians are participants, right? That's always a big challenge. We love our physicians. Challenge, that. And then what we learned, of course, setting up this framework was a lot of work, right? Multiple meetings. Tracy and I still meet every week. We have a standing meeting every week, even if it's just like, I don't have anything new for you, but this is what I'm working on. This is what she's working on. Just having that touch point just to keep us on track, right? Doing those Gemba walks, talking with your staff. I think somebody asked yesterday, like, how do you get the staff buy-in? Talk to them. They're the ones that are doing it. They know either what they need or what they don't need, you know, have them join your committees because they're going to be the ones that are giving you the ideas, right? They're going to ones that then are going to be bought into what you're doing and to help support you. And then we always say the patient is somebody, right? We don't like saying, you know, think about it as your mom or your dad. Maybe you don't like your parents. You might not. But it is somebody, right? And then I think the big switch for me was about a year ago or so. I don't know where I was just thinking about stuff in, you know, in healthcare. It's like, what industry are you in? Oh, I'm in healthcare, right? No, I'm in the customer service industry with the side of healthcare, right? That's really how we have to try to shift our mindset, is that we are in the customer service industry. We're just providing them with healthcare. You know, like you think about, oh, you're in the restaurant business, you're in the customer service business or anything like that. That's what we are too. We just provide that healthcare piece on the side.
So we hope that, I know we always know our talk that we did at AHRA was almost, what, it was 90 minutes.
Yeah.
A lot of information. So this is like the condensed version. But what we really want you all to do is just take, I hope we gave you some tidbits. So just simple things you can do. ADIF training, very simple. Looking at your scores every month and making the staff aware of where they're doing well and not. And the staff, they are, like I said, it's not just me and Jamie. We have committees, committee members to help, but just making them aware, they will make the change and they will buy into that. We are being held accountable for our metrics from a system level. And so, like Jamie said, this is being rolled out, some of the things that we created on a system level as well. But any questions, comments? But thank you all so much for your attention. Any comments or questions? Think we've been able to change much of anything.
Yeah.
I think it's driven by the survey company and what they ask. We're not able to,
Yeah, we have, the organization has added a couple extra questions, but there is the standard of questions. But we just kind of analyze all of it. And so obviously we look at the likelihood to recommend as the overall score, but then I'll do a breakdown for each modality as far as this is the range of the questions. And so I always say, are treating you with respect and dignity and friendliness of staff are always the highest, which I always say is fantastic, because I can't teach you to be nice to the patient, right? But then we have right now, one of our lowest areas is concern for safety. We know that's the biggest thing that MRI focuses on, is that concern for safety. So right now we're doing a big push of talking about it, right? We need you to change for your safety. You know, I'm going to screen you yet again, even though you were here yesterday, for your safety, you know, just to try to get that in their mindset. So then when they do fill out the survey, oh yeah, they were worried about my safety, versus all those things we do in the background. They don't know we're doing it for their safety, right? I kind of equate it to going on the airline. They always are going to go through how to buckle your seatbelt. I think we all know how to buckle a seatbelt, but you're still doing it as part of that safety regulation. And if you were to ask me, yes, she went through the safety piece of it, you know?
Yeah.
So it's just taking that deeper dive into each of those questions and then seeing what we can change to try to improve it. But we couldn't physically change the questions. I will say though, when we did I-rounds, we were able to come up with our own questions. So when we do our I-rounds, again, it's through Press Ganey and it's in their I-rounding platform, is we were able to do our own questions in. So we do ask, did you experience any delays? If they say yes, were you informed about those delays, right? Because that's kind of a two-part question. If you just say, were you informed about delays? Well, if they say no, maybe it's because they didn't have delays, right? Were you provided education on what was to expect before they started your exam? That's one of the next big things, is I want to tell you what's going to happen before I work with you, versus coming in the room and I'm just like, okay, we're going to take your chest x-ray and I'm putting the plate behind you before you even get a chance to say yes or no. And then did you have the opportunity to ask questions? That's another area that's been a little bit of a lower score. Maybe they don't have questions, but still were we able to ask you questions?
Yeah.
And then we do ask if they want to recognize anybody or if they have any comments or suggestions from us. Again, there are patients. What do you guys think? You know.
Do you have a question?
Yeah.
Did you have a question?
Jose.
No. Yeah.
Yeah.
Mhm.
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 Yeah, we always say we're seeing our patients on their worst day, right? It's always going to be their worst day, even if it's for chest x-ray, like Tracy said. What is this chest x-ray going to potentially tell you? Because I've had shortness of breath for a week, or whatever the case might be. It's their worst day. And we always, whenever we do the classes, I always also say, whenever we talk about the patient, we're also talking about family and caregiver also, right? So I don't want to ignore that family and caregiver that's with them. We're talking with that whole entire team that's with that patient.
Yeah.
You had a question back there?
Hmm. What's that? Hmm. So it's like a bonus that they get if you meet your metric. How much is it usually? Okay. Oh, wow. I like it. Cool. Yeah. Everybody loves money. It's incentive, right? Yeah. 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 Mhm.
Yeah.
Uh-huh. Mhm. Mhm. Awesome.
Yeah, we have patient family advisors. We've done focus groups with them for breast specifically, and then other general areas. Again, hearing from them, like, what do you guys want to see that we can try to do differently? So,
How many of you look at your scores, your top box scores? It's good. It's good. Do you go through your comments? Look at them and yeah, it's a big thing. Yep.
all right, thank you all.
Thank you. If anyone has any questions, we'll be here for a minute. So.